Good morning. This is Leslie Stanovich, and I have Bill Wiley and Sharifa Navos from GHA on the line with us as well. This is our monthly Georgia Discharge Data System user group, and I hope that everyone did not have any trouble joining the call through our new platform. Before I go into that explanation, can everyone hear me okay? Can everyone hear me okay?
Yes.
Thank you. I wanted to make sure I wasn't just talking to the wall. Anyway, we, over the last couple of months, we've rolled out a couple of new technologies. One, through our new email system, we are sending out the invitation through our click dimensions, which allows us to manage the contacts better in our system. We can see, when somebody's email is bounced back or when it's been blocked from GHA, and so we're able to manage that better. And we have rolled out Zoom, which I don't know if many of you are familiar with or not. That moves us away from the traditional conference call-in line and WebEx or Skype. So that's what GHA's new platform is going to be, and I hope that everyone was able to log in without difficulty. Also, through that invitation and through Zoom, this is a recurring meeting that you should have been able to download to Outlook and add to your calendar. So hopefully that was helpful to you. I know I'd had several requests, could I send out a reoccurring event for those to add to their calendar. So hopefully you were able to get that imported into Outlook and added on a monthly basis. Any questions about Zoom? Anyone have any difficulty or have any questions? All right. Actually, I do not have the lines muted, so everybody should be able to interact. We do have the option to mute people, so please, if you have side conversations or place us on hold, if you wouldn't mind muting yourself, that would be helpful, or we can mute you because we don't want the background conversation coming through on the line. But with that, we'll move forward. There we go. Can everyone see my screen okay? Actually, I believe almost everyone is muted. Let me unmute you all.
Yeah,
everyone see my screen okay?
Oh, yes.
There we go. Thank you. Thank you.
Yes.
I did have you. So please bear with me and be patient and forgive if I trip up on this new technology. So today we're going to talk about the the submission schedule. We're going to talk specifically about patient type definitions as it relates to the data submission and the readmission module. We're going to talk about the reports and recordings that are available through the data services section of the GHA website. We're also going to take a quick look at the strategic planning module and some updates that we have in development. And then, of course, there'll be time for feedback from you and questions. And if you have any requests for anything to be demonstrated, we'll be happy to do that as well. As I always do, I like to give just a quick overview of what the Georgia Discharge Data System is. All of you, the facilities that participate in the Discharge Data System, submit their data in the UB04 data format to our vendor, Heidi. That data is then processed and becomes the Georgia Discharge Data System. It's distributed to GHA, and on your behalf, we submit that data to the Brain and Spinal Trust Fund Commission, the state of Georgia, AHRQ, and we participate in the Healthcare Cost and Utilization Project for research purposes. So that is just an overview of this data program, and we make the data available back to facilities through our visualization tool powered by Javion through that web platform. Going to talk about the schedule. We are on our monthly schedule, but we are approaching the deadline for the 2018 discharges, to all the corrections to be submitted and made. We're going to try to close that database between July 15th and July 31st. Sharifa, would you like to give us an update on where we stand on the 2018 data set?
Yes, good morning, everyone. The 2018 data set is still, I guess you can still submit, so it's still open. You can still submit corrections. There's a few facilities that we're changing some things, correcting.
Thank you for calling Augusta University Health. We value your time and we'll be with you as quickly as possible. Please stay on the line for.
There, I muted everyone. Let me unmute Sharifa. Okay, Sharifa.
You can hear me?
Yes.
Okay. Yeah, I was saying that, yeah, the database is still open. There's a few facilities that are submitting corrections and also resubmitting data based on seeing, coding errors or errors or things that they missed throughout the year. So we'll be reviewing that data, and I will be emailing you if I see anything that needs to be resubmitted. And you have until mid-July to make sure that your 2018 data set is clean and has all the data in there and the corrections are fixed. And so we recommend that you fix those in your system first, extract the data, delete the old data file in HIDE, and upload a new one. If you have any questions, you can always contact me, but I will be emailing regarding what I find, because I am reviewing it throughout until July to make sure that everything is good. And your help is appreciated. If you could go back, look at your errors, and especially in HIDE, if they're above that 3% threshold, just go ahead and correct those and resubmit that data file.
Thank you, Sharifa. And your data review can begin with the reports on HIDE.net. That would be the edit summary and detail and the verification reports. And Sharifa has done a quick recording training session on how to review those reports. We've taken that out of this presentation. However, we are always happy to do a one-on-one Zoom call with you to go over those reports. If you have somebody new on your team, we'll be happy to introduce that new member to the reports and get them up to speed. So please know that we're here to work with you as you need it. Any questions on the 2018 data submission? Because once we close that data at the end of July, we will not accept any new or additional data for the 2018 discharges. And at that time, we'll distribute the final 2018 in August. I'm going to unmute you if you have any questions about that, the schedule or the 2018 discharge data. Any questions? All right, then we'll move along. We wanted to talk about patient type definitions just as a reminder. The patient types are assigned by HIDE, who is our vendor, to each UBO4 record in the data that is submitted. The assignment of inpatient or swing bed is based solely on the specific bill type in the UBO4. The assignment of other patient types utilizes revenue codes and in combination with CPT or HCPCS codes. We encourage hospitals to submit all of their data, and that is to say not to program the data that is to be submitted, but to submit all the data, and HIDE will assign the appropriate patient type and patient category to that record. All other records will be set aside in unclassified. And I have a screenshot of our patient type definitions. This document is also posted on the GHA Data Services section of the GHA website. for you to download if you need that. But as you can see, this is looking at bill types for inpatient and for the swing beds, and then the rest of the patient types, ambulatory surgery, the emergency surge, emergency room, and other outpatient are defined as noted here. This is important because when we calculate readmissions, we exclude swing beds and other patients, and we want to make sure that you're coding these correctly. We've actually recently begun to do a deeper dive and analysis into the patient types. Bill, do you want to speak to?
Yeah, one of the things that we started doing this year, and it kind of highlighted a little bit with the readmission module, was we took the hospital, the annual hospital questionnaire that has all of the different services that hospitals provide, the number of beds, things like that. So it's a combination of our data program, but also our new CRM, where we're able to do some more refined reports and analysis, especially on the advocacy side. And what we saw between those two is we had a lot of hospitals that listed services like swing beds, psych, things like that, that were not necessarily showing up in the discharge data. And then, so that was a little bit of a clue. And then when we saw the readmissions, where we saw a number of hospitals had a high number of 1 to 5 day readmission, we realized that they weren't always separating by patient type. We had a lot that we saw with swing bed, and we had a lot that we saw with psych, where it's a discharge and then an immediate admission, but it should be to a different type, and it's coming back as an inpatient admission. So that may be something, I don't know if the state is looking at this too, but if the state is planning on that, it's going to show a higher number of inpatient admissions than what should be there. So we've kind of really taken on a concerted effort over the last month and a half or so to look at this to make sure that hospitals are submitting based on the correct patient type, because we know this doesn't have an effect on your readmission penalties or anything like that, but it could have an effect on core measures. It could have an effect on planning that the state uses. It could have an effect on anything that they have with public health. So now that we've identified it, we want to make sure that the hospitals know how to submit that properly so that we can fix that going downstream.
And to just piggyback on what Bill was saying regarding core measures, I know that we have the hospitals that work with us on their core measure CMS submission. We identify when hospitals submit their data for that program, some of the geri psych or psychiatric patients need to be coded with either a different CCN number or a different NPI number so that they can be set aside and not included in the inpatient population. So I know that for those hospitals that we work closely with on the core measure program, we're able to identify some of those because when they start abstracting the case, they're like, well, this is a geri psych case, it shouldn't be included in this population. Right. So we're able to work with those. But if you, have those type patients in your facility, and you may want to double check and make sure that they're being coded with a different CCN and NPI number. And if you need us to work with you individually, we'll be happy to do that. Any questions, comments about this issue? Another way to review your patient types, I've done kind of 3 mini screenshots here. As you can see, and this is one of the analysis that we've been doing, is looking at how the patients have been classified. So this facility consistently has swing beds over time, over the last 2 years. So this one, this is one of the hospitals that reported on their annual survey that they have swing beds, and yes, that is being reflected in the data they are submitting. The second hospital, this is kind of a red flag a little bit because in 2017 they were consistent over time, month over month for submitting swing beds, but then here we're seeing some kind of gaps, and so we need to, Sharif is, contacting these hospitals individually just to follow up with them. you know your data better than we do, but we wanted to bring this to facilities' attention just to make sure that it's being coded correctly. And then this is a facility that, due to the new readmission module and the readmissions between 1 and 5 days, noticed that they had a very high readmission rate, and it was due to the fact that they were not coding the swing beds correctly. I pulled in the 2019 data just to show that they are starting to do that, but excuse me, there's some work to be done to see if we can go back and recode some of these 2018 patients to reflect the swing bed population correctly. Can't do anything about, you know, the prior to 2018, but that's part of the purpose of doing this review now. Does that make sense to everyone?
And like Leslie said, I'll be contacting you individually regarding this, but this is this report or this snippet can be found under the report section of the HeidiNet website, and it's the verification report. And so that report kind of gives you distribution and volumes, and you can glance at it. We recommend that you look at it for 2018 and just see if there are any issues or anything that you see. Like Leslie said, you know your data better, so you would see if there are any issues in distribution, discrepancies in volume, because that's what I'll be looking at and contacting you, you know, when I do see some issues.
Thanks, Sharifa. All right, we will wrap that topic up and move over to just talking briefly about the Data Services User Group resources. On the GHA website that everyone can gain an account for. It's easy to do if you don't have one already. But we have sections for member reports and also data services resources under the Georgia Discharge Data System. And specifically under the data services resources, many of you have asked about the presentations that were given in April and in May from Haney's or from the DataGen reports. So the PowerPoint, or I'm sorry, the PDF version of the PowerPoint are located under the Data Services Resources section. And so here you can see this was a national webinar that was held, I believe, last week. And then this is the hospital-acquired conditions and the readmission presentation, and this was the value-based purchasing presentation that was given back in April. And then we also have posted or created a YouTube channel where you can replay presentations. This is also where we're posting our GDDS, our monthly user meetings. So you can see here, Sharifa's gotten these meetings posted as well. And today's meeting will go up, should be probably by the end of the week. So to get to those recordings in that YouTube channel, you click on, after you're logged into GHA and then the Georgia Discharge Data System section, there's a hyperlink that says past presentations can be accessed here. Any questions about accessing previous presentations?
And I just want to, this is Bill, I just want to chime in. You know, the member reports and the data services resources, those are some really valuable tools and analysis that have been done on behalf of our members. You know, just a couple of weeks ago, maybe last week, we posted a number of different models, excuse me, of the different PPS reports. So the impact of the inpatient prospective payment services on each one of the hospitals. There's critical access reports in there for critical access hospitals. We're about to post a number related to rehab, psych, things like that. So these are valuable models that have been paid for by GHA on your behalf. So whenever these new proposals come out, you know, that's something that you can use to affect how you're going to budget for next year and things like that. So, you know, please make sure you check these on a routine basis. We probably add 3, 4, 5 different reports, you know, every 2 weeks or so. This is the season where we get a whole bunch because this is when all of the proposed rules come out. So we're uploading quite a few now, but you know, please be aware and check back on this on a regular basis. If you're not on the distribution list, which everybody that has access to the folder should be on the distribution list, and we'll put in there which ones have been updated recently. So if you're not on that, please let me know and we'll get you added, because those are some really valuable tools for hospitals moving forward as regulations change.
And what I'm showing here, just as a quick reminder, is, you know, obviously you're only going to see your facilities files.
PPS report.
And we've got them divided, your economic impact report, which GHA generates, but then there's a finance folder, a policy folder, and a quality folder. So in the finance folder, there's, you know, a lot of reports here. We also have, these are the most recent, I believe, and Sharifa has kind of, not, I guess, archived, but just put them in a separate folder for 2018. So these are the most recent reports that have been published.
Right.
And so that's the way these are organized, kind of grouped by finance, policy, and then quality. So like the hospital-acquired condition reduction program is here. The various quality reports are here as well. So you can take a look through all of those, and again, you should get an email blast when these reports are posted.
And we post them as we get them. So even if the last only goes out, you know, every other week or so, that we're just doing that to keep from spamming you. As soon as we get them and we have the opportunity to post them and model them and do all the quality checks on it, we're posting them almost instantaneously.
Any questions? Any feedback regarding these reports? And if you're not the person who necessarily would be the one, you know, interested in these reports, you may want to check around with your, you know, your CIO, COO to find out. All C-levels should, you know, would be interested in these types of reports. All right. So that brings us to talking about the visualization tool powered by JVON. This is just a screenshot of the home page. We met with the team at JVON a couple weeks ago and just talked about a couple of additions, enhancements that we'd like to see. So kind of wanted to start a discussion and get your feedback about what would be helpful. This is one of the main reasons we have this call, is to talk about your access back to the data and how you can use the data for your facility's purposes. We're talking about adding, we know with the migration over to the visualization tool from Analytic Advantage, some users lost the capability to do real data digging, I guess you would call it. So we found that we had two ends of the spectrum of users. We had what I would call super data users and users who just need a point and click and need a visualization of the data. So we are trying to find that happy medium for everyone. And one of the ideas that we've discussed with JVON is adding a tab that would have some drop-down boxes and check boxes where you could select, you know, possibly 10 columns or so, and basic criteria of data that you would like to download that would be beneficial for your facility. So this is just kind of a quick suggestion, or to start the conversation, of data elements that we would have on this filter page. Obviously, date range, facility or facilities, patient type, payer type, patient county would be important, I believe, patient zip, age bracket, and these two that we don't have currently are primary diagnosis code, which would be applicable to inpatient only, the DRG, the care service line. You know, we're not trying to recreate, we offer the limited data set to hospitals who want to subscribe that, which is the de-identified patient level, the entire, data set that they bring into their own system and do analytics with that data. We're not trying to recreate that or undercut that at all. What we are trying to do is provide you with the best experience and the most useful tool that we can. So I'm going to stop here and pause, hopefully not uncomfortably, for a few seconds for you to chime in. I believe I have the lines open unless you've muted yourself, but I really do want to have some discussion about what you would find helpful and how you would potentially use this.
Leslie, this is Cameron Milton. I know we've had a few discussions about this. There are a couple of fields that would be specifically useful for us, and if these are more toward that data set that we need to talk about, but some of the key ones might be attending physician, discharge disposition, and ethnicity.
Great.
Race. Race and ethnicity. This is Martin Adeline. And when is this filter tab going to be available, please?
We are not exactly sure yet, but that's why, we're trying to mock something up to give back to JVON, and then they'll have to give us a time frame of when they think they can have it developed. But we didn't want to just move forward haphazardly without getting feedback from everyone about what would be the most helpful.
Well, I agree with the observation so far. The attending of record is very important.
Could we also include gender?
Gender?
Sex is important too.
Right.
And then the admission source is something that has been used a good bit in the past, whether or not it's coming from an office or self-reported.
Great. Anyone else? Thank you very much for that feedback.
Leslie, I have a question. This is Julie Ballantyne with Northside. And first of all, thank you very much for having those discussions with JVON. I think this could be very helpful for an organization like us. So thank you for doing that. What I'm wondering is, in the current HIDE tool, we are able to kind of import our own definitions, whether it would be a service area or a DRG grouping. With this enhanced capability with JVON, would there be an ability to, create your own definitions like there is in HIDE now?
Julie, unfortunately, I believe the answer is going to be no on that, due to the fact that the licensing, this is a Tableau-based platform, and due to the licensing, there's not going to be, unless we purchased a license for every single user or facility, we're not going to be able to provide the ability to save a filter. I understand where you're going, and unfortunately this time, I don't believe that's going to be available. We are in discussions, however, with potentially creating some reports that we might push to people on a, as a new quarter of data is released, we would automatically push a report to you. So we could work with facilities one-on-one if there was a specific need where we could push a report to you on a quarterly basis on your specific criteria.
Okay.
What other ideas or feedback do you have? All right, well, just if you have thoughts after this call, please don't hesitate to email me or call me individually, you know, to further this discussion. I am in the process of kind of mocking something up to give to Javion to get an idea of how long it might take and how it would work to implement something like this. But to tag on to something I think a couple of people said about attending physicians, we are also talking about adding a physician's tab where you would be able to, and we need your help identifying the data elements that we would need and how that would look. So, you know, attending physician, the operating, and then there's a third physician column or field placeholder, whatever you want to call it, on the UB that is really reserved for the hospital to put whatever physician they want to in that third placeholder. However, the first is reserved or defined as the attending, the second, the operating, and the third, again, is the hospital's discretion. So it would be a tab similar, in my mind, to the revenue code analysis tab. And I crudely tried to mock something up here based on the revenue tab, where you would continue to have, you know, the similar filters at the top. And then I would think that we would want to see the physicians, you know, and then the facility, because a physician could be more, you know, could, you know, be working at more than one facility, have the counts, and then have possibly a service line distribution. But I really do need your assistance on how we would want to visualize or use the physician's tab. And would that be helpful? Again, I'm asking for your feedback.
Leslie, this is Kim Reynolds again. From our area, I think that would be helpful. We would certainly use it. And then just one additional comment. Were you planning to put zip code on the other data set that we were talking about?
Yes.
Okay, perfect. Thank you.
We assume some things are just basically standard. Where they came from, what facility they went to, even that when we start talking about 10 column, some things you just have to have in there. Dates, stuff like that.
Thank you.
Is the service line distribution of the physician, is that going to be helpful for you? And then again, the grouping or visualization of the age bracket, or had you rather see the discharge disposition with the physician? I mean, those are the kinds of things that I'm interested in hearing from you.
Leslie, this is Martin at Erlanger. I
Yes.
believe the position distribution by service line would be of some value because you get physicians that, you know, don't always practice within the confines of their specific specialty kind of thing. So if you can get a sense of what a physician may be doing, you know, across service lines, that would be of value.
Great, thank you, Martin, for that feedback.
This is Allie from Shepherd. My thought is I would think it would make more sense to do discharge disposition rather than age. If it's a pick one or the other, you know, age is something that's descriptive of their population, but discharge disposition may be more an indicator of decisions they've made versus circumstances that have happened. Just a thought.
Thank you, Allie. That's good point. Very good point. Any other comments?
Leslie, this is Julie again at Northside. Are you anticipating that this physician view would be just available in the visualization tool, or would there also be a component that could be downloaded?
Well, in all of the two things, and you know, on this filter tab, I think we could talk about adding the attending physician here. where you could download that data. But then on all of the visualization screens, and you're familiar, there is a way that you can download some of the data. So I think we would have it in both places. Does that answer your question, Julie?
Yes, thank you.
Uh-huh. Any other thoughts?
This may have been discussed already. This is Kelly Guzman. For the service line grouping, is that something we can have access to? I assume there's some DRG groupings for services.
Yes. I intended to have that care service line on as a filter that you could select.
Got it. Thank you.
You're welcome.
Leslie, this is Martin one more time. Another element that might be of value is the principal procedure code if it's a surgical case.
Okay. Any others? All right. Well, we'll close that conversation then. But if you have other thoughts after the call or as you're using the tool, we really welcome that feedback to take back and consider. And that's why we have this group every month, is to talk about the data and how to use the tool. Is there anything anyone would like to see demonstrated on the live tool? I know one thing that we were, just looking at as well, and I may have probably logged myself out, but maybe not. But I'm on the live tool now. And so one thing that I think we would request that you do in review of the 2018 data is to, and I'm just going to pick on Appling, I guess, just that they're at the top of the list, and look at your discharges over time, and just to see, like, year over year, and this is just 2017 and 18, but if we went back to 2015, just to see over time your discharges, and we can sort that by patient type if we were to just look at inpatient. Just to make sure the distribution makes sense to you, especially as we are considering closing 2018 soon. Just at a quick glance, it might help you see any red flags or anything that you need to pay attention to. You can see, obviously, your primary payer type for inpatient down here. So you can also use this tool. Sometimes looking at it visually may be a little bit easier than looking at the black and white verification or edit summary reports. So it asks that you take some time and have different eyes on it as well. It also might help you give some feedback to us on the tool itself. And we just would appreciate that. And also would appreciate hearing back from you how you're utilizing the tool, how you're using it. Are you using it, daily or weekly or monthly? So any discussion about how you're actually using the tool?
Leslie, this is Martin.
Yes.
I guess one question in that regard, since we're in Tennessee and, we're going to be combining Georgia with Tennessee data, we use the THA service lines, which are different than Georgia. So would you all consider doing like a second service line definition from the THA scheme to make it so we wouldn't have to download detailed data for the combination of the two states' data?
Yeah, I don't know how we would do that. I mean, the service lines have been in effect, and we've got a lot of historical stuff with that. They've been in effect, what, 15 years or so?
Right. And are you focusing on outpatient, Martin?
Inpatient right now, but outpatient would also potentially be an area of interest.
Yeah, the outpatient side, now that we're assigning a primary CPT, it should be very similar across really any state that uses HIDE as their data processor.
Okay.
I don't know how we would go about on the inpatient side. They may be similar. We may just have a certain, we may.
THA follows the HANIS service line definition, which I think yours is different than that.
Yeah.
It could be. We probably just need to go offline with you, Martin, and discuss that possibly with Heidi, but we'd be glad to do that.
Yeah, because that would involve us reprogramming several different things that we've had.
I'm not asking you to do that. It was just a question.
Sure, sure.
Thank you.
Thank you. Any other questions or feedback regarding the visualization tool? Well, won't hold up any more of your day then. We are scheduled to have our next call on July the 3rd, and we are going to have that call since we're going to be, talking about closing the database for 2018. I know that many of you may be have vacation plans that's the week of July 4th, but we will continue to have, or we will plan to have the call on July 3rd. But in the meantime, if you have any questions, concerns, anything you want to discuss, please feel free to reach out to any of the three of us, Bill, myself, or Sharifa, and we'll be happy to provide training or a one-on-one review of your reports. Just please reach out to us and let us know how we can be of assistance to you. With no more discussion, we will adjourn today's call, and I thank you very much for your time. Have a great week.
Thank you.
Bye.